Good morning, everybody, and welcome to today's palliative care education session. I'm just going to go over a few housekeeping notes before we get started. I'd like to give a notice of recording so that please be advised that this session is being recorded, and if your camera is on, you may be included in the recording. We recommend turning your camera off to lower the bandwidth needed to view the presentation. The Northern Ontario School of Medicine respectfully acknowledges that the entirety of the school's wider campus of Northern Ontario is on the homelands of First Nations and Métis people. The medical school buildings at Laurentian University and Lakehead University are located on the territory of the Anishinaabe Nation, specifically Atikameksheng and Wahnapitae First Nations and Fort Williams First Nation. If you have any questions throughout the presentation, please send it to the host, myself, Sarah Basnet, and it will be forwarded to our moderator to be asked during the Q&A portion. You can also type your question in the chat publicly. We will not be accepting verbal questions throughout the presentation, and so please ensure to keep your microphone muted. The Planning Committee has received financial support from the Ministry of Health and Long-Term Care in the form of their annual operating dollars. All presentations have been viewed ahead of time in the interest of mitigating potential bias. So with that, I'm going to hand it over to our moderator for the day, which is Elena Robertson. And you can go ahead and unmute yourself. Sorry, there you go, Elena.
There we go. Good morning, everyone, and welcome to today's session. My name is Elena Robertson. I'm a registered nurse, and I am a palliative care coordinator for home and community care at the Northeast LHIN here in Sault Ste. Marie. So it is my pleasure to introduce to you Dr. Heather O'Brien as she talks to us today about updates in MAID.
Good morning, everyone. Okay, I think you can see the slideshow now?
Yep.
Okay, well, I'll just tell you briefly about myself. I'm an anesthesiologist with a little extra training in critical care, and I've been practicing in Sault Ste. Marie for about 15 years. I made a mid-career move up here, and I've never regretted that. As far as MAID goes, when the government announced that they would enable MAID to become legal with about a year's notice, I immediately got on the phone and talked to my family doctor at the time and made sure that that family doctor was supportive of MAID, because I certainly was and wished that that would be accessible for myself from someone that I had already a long-standing patient-physician relationship with. In fact, not only was my family doctor on board, but also became a colleague in the provision of MAID here. And because practically there were only two of us doing this, we found ourselves doing first and second assessments, and I felt that the patient-physician relationship was inappropriate because we are supposed to be independent. So I now have a new family physician and a colleague that supports MAID practice, so it's worked out very well for me. I was approached by Sarah a couple of months ago to ask if I would make this presentation for you, and the subject is supposed to be medically assisted dying in 2021. So we want to look at the northern context, and we also want to look at the paradigm of COVID, which is impacting us all. I recognize that all the communities involved in NOSM have been providing, to a greater or lesser extent, MAID care, and as physicians with interest in practice in palliative care, I'm presuming that you all have a basic familiarity with the background on MAID and may in fact have participated in assessments or at least referred some of your patients. So I'm going to use the learning objectives that Sarah sent to me, looking at MAID statistically in the province and in the north specifically. I'm going to look at how, if any, MAID has been impacted by COVID. And then I'm going to compare the relationship between palliative care and MAID. And I suspect you guys have gone over this over the last couple of years. Everyone has a slightly different perspective on this. And I certainly will be happy to take any questions in that regard at the end of the presentation. lastly, I'm going to look at some of the challenges for MAID that we have because we practice in the north, typically in that more rural communities, although I do recognize that we have 4 fairly large centers in the north as well, and you will be represented in those groups to some extent. So the data that I have here in front of you on MAID is data compiled as of the end of November 2020. Just this week, I got updated data, but it hasn't changed significantly. So this is composite now over the course of the last 4 years. What I want you to notice here is that, as expected, female to male ratio is about 50-50. It's exactly 50-50 at this point. The age range and average indicate that it's typically provided to elderly people, although it is quite an extreme range of age. I think that the youngest patient that I have had has been in his 30s, but that's definitely an exception. The diagnoses, as one might expect, are the terminal diseases that you care for as well. Cancer being the majority, 63%, cardiovascular and respiratory, 17%. So that would include typically heart failure patients and patients with advanced COPD. Neurodegenerative, what I'm seeing the most are ALS patients. I had no idea how many we had. And also some patients with MS, although that one is a little bit harder because the disease course is a little bit slower for most people. 9% various other diagnoses. And MAID patients are eligible to be organ donors. In fact, when we do our assessments of the patients and we find them eligible, we now have a reporting obligation to call Trillium prior to the death and let Trillium lead the process of determining if that patient might be a donor based on their medical status, and then, if eligible, contacting the patient and their family to discuss the possibility of organ donation.
Heather, sorry to interrupt.
Yeah.
I was just going to say, I don't think your slides were advancing on our screen, but I see it now. So sorry.
Oh, so we're okay?
Yeah, we're at the cumulative data now. So.
Right. Yeah, I'm just talking about organ donation because it's part of this, but we can go back to that in more detail later, perhaps in the question section. In the slide in front of you, you'll see that the ratio of patients having MAID care at home is quite high, 47%. It says here. In fact, this week it's gone up now to 48% at home and 42% in hospital. I think that was a bit of a surprise for hospitals who anticipated that they would have the burden, I'll say, of caring for MAID patients to a greater extent than they have. I'm not particularly surprised by this. I think most patients that I've had in my care have preferred to have MAID delivered in their home. And certainly in Algoma, in Sault Ste. Marie, the vast majority have been at home MAID delivery. These numbers are broken down from, again, the same set of numbers, looking at the different regions in NOSM's area of interest. And you'll see that compared to the province-wide rate of 0.07% MAID deaths per population, you'll see that there's quite a range here. Not surprisingly, North Bay is doing extremely well. That, I believe, is on account of Paul Preston's advocacy, Paul being well located politically within the LIN and also a very strong advocate for this. Nipissing actually has the highest rate of MAID provision per population of any region in the province. At the other end of the scale is Sudbury, much lower than the Ontario rate, and about half of the rate in the rest of our region. When you look at the reasons why a particular rate comes out, you have to consider a balance. The balance is, on the one hand, access to care, and on the other hand, what drives patients to request medically assisted death. I think that both issues are significant, and I think I certainly have felt the impact of few providers and being required to travel some distance to care for people because I was the closest person willing to do that. On the other hand, you also have to look at our patient population and what resources they have access to. If you compare two people in two different situations with the same burden of health, then you have to look at what the other supports are. Obviously, family comes very high up on that. There should be no difference there for the most part. Next to that, you have to look at income and income disparity and how that balances with the cost of finding care for yourself. So if you live in Toronto, you can take a bus to tertiary care. If you live in the north and you need perhaps tertiary oncology care, you may well need to travel some distance, which costs you money, takes time, and as your disease progresses, becomes harder and harder to do. So you may suffer more from your disease than a patient with an equivalent diagnosis in Toronto. Other resources in the north, you may have difficulty accessing some home care services if you live remotely. And you may have difficulty even accessing a pharmacy depending on where you live. So these issues all play into the balance. But I think on the whole, in the north, we should be proud of our efforts to maintain access to patients as much as possible. As far as COVID goes, we're settling into COVID, and it's becoming the new normal for the providers at least. For our recipients of healthcare, I think the majority, we recognize if they go grocery shopping, they have to wear a mask. If they go outside of the house and they're ill, they're going to be masking and such. Some of our patients, however, have been pretty much bed-bound and homebound by their conditions for some time, so they may not really be living in that paradigm the way that we just take for granted now. There was a concern that COVID-19 would lead to an increase in the rate of requests for medically assisted dying. It really hasn't, but it's changed the context a little bit. So some patients did make requests so that if they caught COVID, they would be able to go ahead. But of course, that's sort of a pre-approval, which is not allowed under the legislation. So if a patient is not experiencing a condition that would lead to a foreseeable death at the time of assessment, they can't be found eligible. So that parked that group of patients. The feeling is that some of the candidates for MAID may be advancing their requests to an earlier stage of their disease course or wishing to proceed a little faster from assessment to delivery. I think that may be significant because of the impact of isolation on these patients. And as I mentioned before, family support and community support, medical support are all very important to many of these patients. So this is probably going on. And on Ontario, Julie Campbell from the Ministry Hotline has certainly indicated that this is her perception province-wide. The situation has changed in terms of the options for patients. So institutions such as hospitals, hospices, retirement homes, they've curtailed or prohibited visiting to a great extent. This means there's more isolation for the patient, and the patients are less likely to wish to transfer or stay in these institutions to have medically assisted dying. So some of them are being discharged home to have MAID there within hours of arriving home by their wish. The hospital, I know, is also juggling beds, trying to achieve as great a capacity as possible, and we have had the benefit of a dedicated MAID room here that we only use for that purpose, and at least temporarily that's been taken away. I'm assured that if we have a death that is to be scheduled in hospital, a bed will be found without me having to scramble for it. But I haven't had that situation yet. I haven't had an in-hospital MAID death in months now myself. By necessity, we're doing a lot of our assessments of patients on OTN, and I think you're probably all familiar with using that. So I've done many of my out-of-town and some of my in-town assessments via OTN. It's not ideal, obviously. The more intimate the discussion, and when you're talking about end-of-life discussions, you all realize that they are very much so. The more you want to be able to look the patient in the eye and see full face to full face. In fact, with the masking requirements, we can see more of the patient's face and our own face when we are on OTN, but it just isn't quite the same as being there. I think, though, that because we're doing so much more with OTN, we're all going to be familiar with it, and we're all going to jump to that a little more quickly than we would otherwise. Might be a disadvantage for some of our patients because in many cases, in my own home included, internet service is limited, and some patients may not even have a cellular phone to be able to make a FaceTime call. Typically, we're not screening here anyhow. Our patients for COVID, if they're requesting MAID, that's not an indication unless they had some of the other symptoms. So when I go into a home of a patient requesting MAID, I have no idea if they've been positive or not. I do pause at entering the house to ask if there are any risk factors within the home. And certainly I wear a mask when I'm in the patient's environment, unless they specifically request that I remove that. Now we've upgraded our recommendations, so a face shield is needed, and I have a full face clear shield, which I can wear for my own protection. Some MAID providers are pausing when they come in a home away at a distance from the patient and family and removing their mask and then putting it back on for the assessment and provision. I think that we'll know that respiratory symptoms are common in our COVID patients, but actually no component of the delivery of MAID or the assessment of MAID would be considered to be aerosol generating unless the patient's on BiPAP, and patients such as the ALS patients often will be. So that increases the need for PPE and would include the use of an N95 mask if you're within a few meters of them. I think you all know from your in-home care and in hospital, if that's where you provide palliative care, is that full PPE is really uncomfortable and cumbersome. You may have more challenge with technical things such as starting an IV because of the diminished visibility and full PPE gear. And I think also people have probably learned that when you start to get a little bit emotional and your eyes water, you'll get the sniffles, and that's really quite unpleasant when you're wearing a mask. So do keep in mind that MAID care, like palliative care, of course, is often emotional for both you and the family, and tears are expected. And I always tell my patients and their families that they should feel free to express their emotions during the procedure, and that I take every effort to let the family know what I'm doing and why I'm doing it and what to expect, so that they're not shocked and they don't have to worry about sudden waves of that type of emotion. I'm going to go on to the discussion about the relationship between palliative care and MAID, and I don't think that this topic is going to be new to any of you. Certainly when we introduced MAID in the country, there was concern, widespread concern among the palliative community that palliative care providers would be seen as purveyors of death as opposed to providers of care if they endorsed, discussed, or provided MAID. Again, this is an issue that I think has settled down across the country to some extent, and everyone, of course, is still entitled to their opinion, and we all lie on a spectrum in terms of this. My own personal position is that patient autonomy is paramount, and I will make other ethical decisions around that. I sleep quite all right knowing that I'm doing this from my own values. When I did my first MAID provision, the night before was quite difficult for me because I found myself thinking about what the patient might be thinking about on the night before their scheduled death, and I had never been in that situation before. I really did not know how I would feel in providing care and after I had provided care. So that was a pretty anxious moment, and I was one of the early providers in the country, so I didn't have a lot of mentoring to call upon. I think now, for anyone in the audience who might be considering providing for the first time, they will also have those emotions because it is a unique personal decision. However, at this point in time, at least now there are a lot of mentors available, and depending on where you live, you may have a colleague who's been providing MAID who would come with you or at least debrief you after your first MAID. Once my first case was done, I saw the relief on the patient. I saw the relief on the faces of the family members, and I felt a great burden off of my shoulders, actually. And I continue to feel a sense of calm after providing MAID. I don't have any disquiet about it. So I think as palliative care providers, you also value the autonomy of the patient. So this is something that we have in common. We're both aiming to provide both physical and psychological support to the terminally ill. Your role, in contrast to mine, is a little bit more longitudinally generally. I will have some patients that I meet and assess and then don't provide for till almost a year later, but I don't have that weekly contact with them. Also, palliative care is much more long established in Canada than MAID, so there's some differences there. Again, I mentioned the initial hesitancy within your community. In my community here, my palliative care physicians were very reticent to get involved in MAID initially, and then I started to get some referrals from the palliative care doctors, and initially these ones, the first half dozen or so, were too late. By the time they referred to me, the patients were no longer demonstrating capacity and they would not be eligible. That's improved. That improved very quickly with a little bit of feedback. And now I have the majority of my palliative care providers in Sault Ste. Marie being willing to act as assessors for the patient, because they do require 2 assessments. So I do one, and I need a second physician or nurse practitioner to do the other. And I'm very appreciative of the support that I get from our palliative care doctors. I want to remind everyone that you do have a duty to provide a meaningful referral for MAID if care is requested by a patient. That is, if the patient requests it verbally or in any other form. If the patient does provide you with any form of written request for MAID, and that can be a text message, a note on a napkin, or a formal completed clinician aid A, then you have a duty to determine the outcome of that request. If that patient that has requested MAID does not get MAID, so if they die of natural diseases or they go on to live more than 6 months, you also have a duty to report to the federal reporting website. It's easily found on online if you search MAID federal reporting. And it's a 5-minute assessment just asking some details about the patient and about the nature of their request and your handling of it. So that is important because that's legislated. I think that palliative care doctors I have not had present with me at the time of MAID delivery, but many of the nurses who've been providing palliative care in the home will ask to be there, and the patients are very grateful for that. So I've had their company and appreciated their help during these procedures. Typically, as an anesthesiologist, I have no difficulty with IVs, so I go alone. I don't require anyone else to assist me. I think it's very obvious to me that many patients find as soon as they've been told that they're eligible, they can relax. They have a great sense of comfort knowing that they're eligible and that they're in the driver's seat as far as MAID, whether or not they choose to proceed. And lastly, natural death, even with ideal palliation, is often accompanied by confusion, delirium, and some patients just don't want that. Even if it is peaceful and painless, it's not what they want. They want to be clear-headed when they say goodbye to their patients. And I have seen some very poignant moments at the end of life. Even my most recent patient was reconnected with a son he hadn't seen since the son was 2. And that was very, very moving. So very important to the patient and the family. Challenges for practicing MAID in our rural communities are several. We do love the North, I certainly do, but I do acknowledge the limitations in terms of many things with regard to MAID. It's more difficult for our patients to access in-person primary and specialty care. We have a large number of patients that don't have a primary care provider, and certainly access to oncology is difficult at the end of life because it's hard to travel. It may be the case that you have less availability of in-home support services if you live far from an urban center with organized care, and to get someone out to your home may take longer in terms of minutes, hours sometimes. And depending on what you're asking for, if you're looking for MAID and a provider doesn't live anywhere near you, it may take that provider a day to get up there. So response is not as quick as it would be if you were in an urban center. Organ transplantation for patients who need to receive an organ, who have organ failure, typically kidney failure, but liver as well, they will need to reside in Toronto if they're going to receive an organ. So to be on the active list, they have to be living in Toronto. For many of our patients, that's out of reach. They have no family there. They don't have an income to be able to support their home in the north and live in a hotel in Toronto. So that may influence the decision to seek MAID. Most MAID delivery is hands-on, so all but 2 of the 6,500 or so cases in the province have been done by intravenous injection. So the provider in those situations must attend to the patient or vice versa. The oral route is an option in remote areas because you can prescribe it, the patient can have the prescription filled, and the prescriptions cost the patient nothing. Then they take the medication, but the problem with that is that it's unpredictable. If they're nauseated and vomit, they lose some of the medication. They may not die immediately. And if you have a patient hanging on for 24 hours, not dead, but not really living on account of your medications, you then may have a desperate family member who calls and says, do something, and you might be required to attend to them. If we're going to do the oral route, and I certainly do not wish to do this, but would only do it if necessary. If you're going to do that, then we're looking at getting sort of a conditional consent to say once you've begun to give the medication, in this case the patient taking it, then the provider has the allowance to go and deliver intravenous medication to change the plan to get the patient out of that purgatory of sorts. I, for one, have a full-time clinical responsibility as an anesthesiologist here in town. I think many providers are adding this to their normal clinical load, although some MAID providers are at end of career and have slowed down a little bit to have the capacity. So if I have a patient request that's out of my community, and I do travel with some frequency to 3-4 hour drive away, I have to schedule that on weekends. It's the only time I'm free. I'm not going to drive at night. And I don't like driving in the winter, but I will do it. So in that case, a patient who calls me and says, I really want it today, it's fine. If it's a Friday, I can get there the next day. If that happens on a Monday, I have to make them wait. And I feel badly about that, and I certainly know that they feel badly as well. So some further challenges, as I alluded to, our weather and our road conditions are really awful. Sometimes unpredictable. If you set a date and that date is a blizzard, you have to really think about what's best in that situation. Fortunately, I haven't been put in that situation yet. Also, although MAID is covered for the patient, they don't have to pay for anything. MAID for the providers, initially when they started out, they didn't give us much guidance in terms of what codes to use, and you could only bill a visit fee, which is fine if the patient's in town. As a specialist, I can bill a consult fee when I see the patient, and then it was just a minor assessment fee for the 2 hours I would spend in the provision. So, although I did it, I felt that the government was taking advantage of us, and it's changed now. They did listen. So all MAID care can be billed at the K023 code, including commuting time. So if I drive somewhere, I am reimbursed for that expense, and I respect that. However, as far as I know, OHIP or the LHINs have not been willing to cover the costs of provider traveling by air. Meaning if I have to buy a ticket to go to Thunder Bay to drive to a remote community, they're not going to cover my airfare costs. So again, it's, do I do that? Do I not do that? If I do it, it encourages the government to continue on with this status quo. If I don't do it, then I'm failing to provide care to a patient who needs it, and I feel badly about that. There is less redundancy among the providers in the north because we live in smaller communities. So you may have somebody who's pretty much the sole provider. I've certainly provided the majority of MAID deliveries in Algoma. if you have even 2 or 3 providers, you're still at the mercy of availability. So if one becomes available due to illness, COVID isolation, for instance, then you're down to 1 or 0 in that area, and the system can crumble. Also, because there's not a lot of us doing it, we are limited in terms of our cultural and linguistic alignment with the patients. It's always nice to speak to a patient in their first language. I can speak some French. I can certainly have a conversation in French, but it's very hard to get into those personal things like describe your suffering. That's hard for me with my limited French. Also, because there's few providers, it's very hard to say no, and I think we all know what that feels like. There may be only a single source for medical care in a community, which may be faith-based. Elliott Lake, for instance, St. Joseph's Healthcare has completely opted out of MAID and will not do anything to support MAID for its patients. And I'm under the understanding that palliative care in Elliott Lake is delivered through the hospital, through the health center at least. So it's difficult for patients, but some of the physicians there I know feel torn by that. Fortunately, in Elliott Lake, there is a long-term care home who's more than willing to accept patients and transfer. Everyone knows everyone in a small town, so confidentiality becomes more of a challenge. Obviously, many patients do not want it known that they've chosen this form of end of life. Some of them actually want it known. They want it shared. They want it sung from the hilltops. So regardless, you as a provider have to be very careful about confidentiality, your fax machine, who has access to that, all these sorts of things. Outside of large centers, our patients don't have the option for organ and tissue donation generally, and during COVID, the restrictions are greater, so that even tissue becomes an issue. And you may or may not have access to a pharmacy that supports MAID care. I'm very fortunate in Sault Ste. Marie. I've had great cooperation all along. Excuse me a moment. So fortunately in the north, we're a pretty resilient bunch. We can generally work around things, and we're creative. So we can almost always find suitable assessors and hopefully a provider. Assessors can be done by physicians or nurse practitioners in Southern Ontario, and in many cases I've resorted to that, and they're wonderful. Another advantage that we have here is that NOSM is very committed to providing both learners and providers of care with tools to enhance our respectful and effective communication with our patients who come from various cultural and linguistic groups. There is the option, as I mentioned, of oral medication, but we've already talked about the pitfalls for that. Again, OTN is very useful. We're also using Skype or FaceTime if necessary, and even over the phone now we've done some assessments. No one likes to do it that way on either end of the phone call, but the coroner is accepting that as a valid form of consultation. The coroner's office is now also allowing virtual witnessing of the patient's formal written request. So the rules for the written request are that the patient has 2 independent witnesses, meaning witnesses that they're not receiving direct care from. They can't be the owner of a long-term care home in which they're residing, and they can't be people who would be expecting to benefit from the estate of the individual. So generally we avoid family members for witnesses, and some patients really don't have 2 people that they're willing to call upon to do this because they want to maintain the confidentiality, or they just don't have that many social connections, unfortunately. So we've been able to do virtual witnessing now with volunteer witnesses from Dying with Dignity or others, where the patient is in their setting and we have a video link of some sort hooked up. The patient does say that they know what they're signing, what it's for. They say it's for medically assisted dying, and they sign their form while the witnesses view it remotely through this video link. They then fax the form to the witnesses who sign the form and send it back. And that's been accepted. It may be a temporary thing during COVID, but I think in the North we recognize that that may be a necessary thing to continue. I talked about the billing codes and our resiliency as providers. So that is the end of the formal part of the talk. I think that Elena's been consolidating questions. I hope they've been coming in, and I'm more than happy to take them.
Okay, we do have a couple questions that came through. So one of the first ones is, can people volunteer to become a witness for the Form A?
Sorry, could you repeat that?
Can people volunteer to be a witness to sign the Form A? I know here in the Sioux we had an issue once where we didn't have any volunteer witnesses because the patient didn't have any friends or that they wanted to know but that they were receiving it, and there was an issue with the volunteer witnesses at that point. So can anyone volunteer?
Do you mean like formal volunteers in hospital?
No, when they need the witnesses to sign the Form A, you know how they need 2 independent witnesses to sign?
Yeah.
Is there any way for people to become these volunteer witnesses?
Yes, absolutely. It's informal here in the Sioux, but I have gathered a little cadre of people willing to be volunteers. Unfortunately, there was a couple who were doing it, and COVID has led to isolation of one of those individuals, so they're no longer willing to come out in person, but would do it virtually. And I have a couple of other other volunteer witnesses. One of my nursing colleagues here and her husband have been witnesses for me. Also, another provider could act as a witness if they're not involved in the care. So yeah, and if you are stuck in your communities, you can call up Dying with Dignity. They maintain a list of volunteers. Obviously, most of them are in urban centers, but you never know if someone in the communities reached out to Dying with Dignity and maybe on their list.
Can a primary care provider agree to primary assessment but request the second assessment carry out the procedure? The second assessor carry out the procedure?
Yes, certainly, and that's happening a lot with references I've got from referrals I've gotten from primary care providers and palliative doctors. In fact, the way it's set up, the patient signs clinician aid A. Clinician aid B is officially the first assessor, and clinician aid C is the second assessor. So that the way the forms are set up, the way the program is set up, there's a presumption that the first assessor will be the provider, but it's not necessarily so. What we do typically is we ignore the timeline and have the family doctor complete the second assessment, which is clinician aid C. And then the person who is expected to be the provider completes clinician aid A. It has a little, clinician aid B. It has a little more detail that you need to collect. So it's better if a patient has a B and a C completed. Although a recent case I had, there was a little bit of, it was a Elliott Lake patient. There was a little bit of juggling about who would be the provider, and it didn't turn out to be the person I expected. It came back to me. The coroner didn't mind that there were 2 clinician aid Cs and no clinician aid B. When you do the assessment, you have to fill out these forms. You also need to do a note documenting the thinking behind your decision making. And that note is typically your clinical note. If you've been, documenting longitudinally with your care of the patient, then some of those notes will do quite nicely, as long as the last one talks about your discussion with the patient surrounding MAID.
And how do we access the medications for MAID, and is there any cost?
Sorry, how do you access the?
How do you access the medications for MAID, and is there any cost?
Yeah, there's no cost to anyone. The pharmacy is reimbursed by the Ministry of Health for these medications. So you have 2 options. If your MAID is being provided in a hospital, You can request the medications by writing a prescription to the hospital pharmacy, and the prescription must say what the purpose of the prescription is. It's fairly obvious to anyone what the prescription is for, but I explicitly state on my prescriptions for the purpose of medical assistance in dying. The hospital, you need to have a conversation with your hospital pharmacy. It needs to be prepared and given to the provider by a pharmacist. A pharmacist tech is not allowed to do this under the legislation, but our hospital will provide that for me. We have a template order set for it, and they provide it in a kit that I carry to the bedside. The provider goes down and picks up the medication from the pharmacy and takes it to the bedside at our institution. I'm not sure if that's actually required, but the pharmacists themselves rarely come to the bedside. So that works for us. As far as community patients having MAID in their home, I had a discussion with one of the local pharmacists that I had some degree of social connection to, and they were very willing to help with this. So in the community, I write a prescription for a kit, one MAID duplicate kit, and I've given the pharmacist a list of what I want in that kit. So what they put together for me included not only the MAID drugs, but IV supplies, gauze, syringes, everything that I would need to deliver medically assisted dying, and it's a duplicate, and that's what's recommended, that you always have a backup supply in case you drop a syringe or the patient doesn't respond the way you wish them to from the medication. The medication that we use, I'll just go over that very quickly, time is going to permit. We start with 10 milligrams of IV midazolam, and depending on how far advanced the patient's illness is, the response goes from being drowsy and mumbling to being apneic. I've seen both ends of the spectrum. It's designed just to make them relax so they don't have any fear of going forward. And that is after they've given you their final consent to proceed. The second thing we do is we inject a little bit of IV lidocaine, because the propofol, which is to follow, causes a little bit of burning on injection, and you don't want to cause the patient any discomfort. So the lidocaine, we give 40 milligrams, 2 cc's of 2%. Then it's followed by propofol, and we give 1,000 milligrams. In my practice of anesthesia, for the majority of the type of patient I'm giving MAID for, I would be giving less than 100 milligrams. So 5 to 10-fold what it would be used to put a patient to sleep for surgery. So we know it's a huge dose, and it absolutely leads to deep anesthesia. For many of the patients, that propofol is going to render them apneic. Some patients are still breathing when the propofol is done. Some patients are actually asystolic before you can put that 100 mils of propofol in. For other patients, the apnea just leads to asystole. After the propofol is given, I check to make sure that the patient's not responding to voice or touch, and then I can give the rocuronium, which is a muscle relaxant, and I give 200 milligrams, which is again about 4 to 5 times what I would normally give a patient to paralyze them for abdominal surgery. So a huge dose of muscle relaxant. That, of course, stops their breathing if their brainstem is still triggering breathing, and guarantees apnea, hypoxia, and a cardiac death follows soon after. I have had to give a second dose of midazolam with one patient who was still fairly alert due to tolerance for benzodiazepines, and I haven't had to repeat any of the other medications in any of my patients. There is an option to use bupivacaine as a final drug given intravenously in a cardiotoxic dose. It kind of creeps me out because in my practice, we try so hard not to have bupivacaine given intravenously. So I wasn't really comfortable about doing that. I have used it once or twice if the apnea didn't lead to asystole within the span of a few minutes, because it is hard for the family to watch their loved one turn dusky but not be declared. So that's it for the medications. I haven't had any trouble procuring them. When I travel out of town, it's easier for me just to use my local pharmacy, get the medication on board. I haven't had to have conversations in other towns with pharmacists, and I really have no idea how small town pharmacies would feel about this. You know, it's a small community. Everybody knows everybody. It gets a little bit more uncomfortable.
Next question. For MAID in the home, can we request a second box of meds not to be opened unless meds from the first kit are wasted, dropped on the floor, or gone interstitial?
Yes, I think I've answered that. It's routine to have a backup set of meds. After the MAID is delivered, we are expected to return the drugs to the pharmacy, the unused drugs, and the coroner may ask you what you intend to do with those drugs. I always return them. I know there were some supply issues with some of the medication, and some providers, I've been told, have been sort of holding on in a locked box to the second set of drugs, so that if they can't get a first set for provision, they at least have that set. I wouldn't encourage that. Hopefully it won't be necessary. It's really a matter of drug supply, and we all know we've been experiencing that with a whole variety of drugs.
I think you answered this one. How do you find a pharmacy in a rural area who can provide the meds?
How do you find them? I guess you kind of look up who your pharmacy is in that town and call and speak to the pharmacist ahead of, hopefully, you know, if you're planning on providing MAID, have that conversation before you have a patient. Then you know the lay of the land.
Is there a culture of needed/wanted anonymity for providers in some areas that are less supportive of MAID, example Sudbury? Do you feel that this kind of culture contributes to further availability of MAID or diminishes awareness of MAID?
Can you just repeat the first part?
There is a culture of needed/wanted anonymity for providers in some areas that are less supportive of MAID.
Right. Yeah. So when we started, I think we were all afraid of people protesting on our front lawns. And in Sault Ste. Marie, we have a history of that when they provided, the local physicians years ago provided abortion services here, and there were protests on their lawns. So they stopped doing that, and although we do provide a termination of pregnancy here in the community, we've been relying on providers coming in from out of town. So many people do compare the provision of MAID to the provision of termination of pregnancy, and they're very different. They both obviously lead to the end of a life. You know, a living, beating heart stops beating in either case. However, from my point of view, although I don't participate in therapeutic abortions by moral decision, but I support women's access to that. I find MAID to be completely different because it is the patients making their own choice. So just to put that aside, our experience here has been that very few physicians have been willing to participate as MAID providers, but steadily growing number of physicians are realizing that they have patients who want this, who are suffering, and when they see that individual, they soften their stance a little bit. So I do have physician colleagues in Sault Ste. Marie who, through, I hope, ignorance, provide their patients with misinformation. A recent patient said that their family provider told them, you can't have this at home, which is, of course, not true. And I've been sharing this with medical staff from the start of my MAID practice. But I'll grant them the ignorance excuse. For the most part, this is pretty well received, and the voices of dissent for MAID have diminished. There's no protests, as far as I know, about MAID in the community. We did have a few sort of meetings of groups of people opposed to it, and you know, the two areas where opposition to MAID was loud to begin with was the religious side. The Catholic Church still frowns upon MAID, so we are an Italian town, a lot of Catholic individuals, so there was a discussion about that. The other group, of course, are the people who live with chronic disabilities who felt that they may be, their value may be diminished in an environment where MAID was permitted. And that voice is still active, and they certainly have a point that needs to be taken into consideration. Just as that group is now arguing that, you know, COVID disadvantages them, it's true. They're already suffering, so they're on that line. But the safeguard for them is the need for them to request it, to be competent, to be eligible, and again, at the moment before administration, to consent. I haven't personally found any pushback. I haven't gotten any dirty looks from any of my colleagues. After about a year of practice, stopped having any concern about public knowledge that I provide this care. My initial patients, I asked them, you know, not to publish my name in the obituary, that sort of thing, but I've given up on that. If patients want to be, you know, quite explicit about the fact that I did this, I'm gonna be okay with that. One of the reasons why I've changed my stand is that my youngest child is now out of school, and I did worry when he was younger that, you know, around the dinner table talk with some of his classmates might come back to him that his mother's a bad person. I know I'm not a bad person, but when you have a child, they don't have the maturity to balance the issues. So is this a problem in some small communities? I really don't know. I don't live there. Obviously, providers need to be available to patients, and I'm just hoping as time proceeds that the pushback against MAID will diminish in the medical community. One of my recent patients actually received last rites from a Catholic clergy who knew that they were going to proceed with MAID and basically told them that God would not judge them on this one. I was very surprised about that. I was also fairly pleased that the humanity outweighed the dogma. I'm not Catholic, just a little disclaimer there.
Can family or power of attorney / substitute decision maker make the choice for the patient to have MAID?
Absolutely not. This is the only decision that a designated person cannot make for a patient. The patient has to remain competent right up until the very last moment, and they have to tell the provider in no uncertain terms that they're asking for MAID, and then they know what it's going to be, and that they know the alternatives. It's a funny sort of thing because, you know, we can, as a power of attorney, you can say discontinue the ventilator, you can say discontinue the feeding, you can authorize the end of life except by this active process of MAID. And that may change. I think we all know that the legislation is under review. A lot of pressure on politicians to go both ways on it. We'll see where that goes. I don't think we'll go to substitute decision makers making the decision for patients, but I think we might go to some sort of predetermination so patients can say, I want this. When I get to this point and these objective benchmarks have been passed, then proceed. I can see that happening within my career.
And last question, are we able to get the copy of the PowerPoint slides?
Oh yeah, Sarah has it.
Those will be posted on the website.
And you can always, if you have any questions, you know, if you're looking at entering these waters and you don't have anyone else to help you, to mentor, to bounce questions off of, you could just look me up at the Sewer Hospital. I'm more than willing to talk to anybody at any point with any questions. Also, Julie Campbell at the Ministry of Health MAID hotline, she's my go-to person. She is a nurse practitioner in London. She's from the Sioux originally. So she does the accepting of requests and referral to clinicians, but she also is a provider in her own neighborhood. She's got the most experience of anybody with the whole picture of MAID in the province of Ontario, and she's very helpful on the phone. that's all the questions then. I really want to thank you for your participation, both as audience members and in the discussion.
That's all the questions that I have. So thank you very much, Dr. O'Brien. It was very informative. So thank you.
You're most welcome. And good luck to you all with the care you're providing.
Thank you all for joining us today. Thank you, Dr. O'Brien. That was wonderful. I just want to remind everybody to complete an evaluation. The link can be found in the chat box, but it can also be found on the website, as well as there's a link there to obtain your certificate of attendance. And you can also do that through the evaluation link as well. And I just want to bring your attention to our upcoming sessions. We have a clinical round session on February 16th at 5 p.m. And it is on psychedelics and the use of psilocybin, the magic mushrooms, for psychological and existential distress at end of life. And then on Thursday, February 18th, we will be having a session again at 8 a.m. on complex pain management. So please join us for those. And thank you very much for joining us today, and have a good rest of the day.